also try and just give you the floor in a moment just to quickly introduce yourself as well to the listeners. But before you do that, I just wanted to quickly reintroduce myself as well. So my name is Benjamin Stetcher. About 4.5 months ago, I had this adaptive deep brain simulator implanted into my own brain. And my guest today is Dr. Philip Starr here at UCSF. I'm in Sunnyvale right now, but I actually owe a lot of this device to him and his work because he did a lot of the pioneering work early on in this field that helped me get to where I am today, basically, and to where hopefully I'll be even better after Tuesday's session with my neurologist, where we finally get a chance to turn on this device and see what all the magic and beauty that it can do. Yeah, thank you, Dr. Starr, for taking time to speak with me today. And I'm wondering if you just quickly introduce yourself, or is there anything you want to say to this audience that we might be having here?
Sure. Thank you. I'm Philip Starr. I'm a professor of neurological surgery at UCSF, and I had my training in movement disorders with a great team of Malin DeLong and Jerry Vitek and Tom Wickman at Emory University and Roy Bakay, the neurosurgeon there. And then got a job out here at UCSF in 1998 to set up the deep brain stimulation programming, and it's been going strong and I enjoy it very much. I will say, if you wanted to credit people for why you have a DBS device now, probably a lot of that goes to French neurosurgeon Alain Benabide, who was the first to do basal ganglia stimulation and show how well it treated Parkinson's. And then also a lot of credit goes to Malin DeLong, my mentor at Emory, who developed a lot of the theory and some of the surgical techniques behind doing this kind of surgery.
I haven't had the pleasure of meeting either of them yet. I know a lot about Benabide and his work, and I've heard of the name DeLong as well. But I do know Hagai Bergman a little bit. I've had the chance to sit with him in his office. And from what I understand, he was a close associate of Benabide's, I think, early on in his career as well.
Yes, correct. And in fact, Hagai was one of the first authors on a very well-known paper in our field with DeLong, from Dr. DeLong's lab when he was at Johns Hopkins. The paper published in 1990 with Hagai Bergman as the first author. Tom Wickman and Malin DeLong was a foundational publication in our field because it established in a non-human primate model of Parkinson's that you could interrupt activity in this case, the subthalamic nucleus, and greatly improve Parkinsonian signs. So very influential paper, and it was a paper that led Alain Benabide in Grenoble, France, who was already doing deep brain stimulation for other things. He decided, okay, I'm going to use the deep brain stimulator in the subthalamic nucleus based on that 1990 paper. So it's a really nice story of a basic science finding giving rise to a surgical procedure.
I always love those stories. I love hearing about them as well. And the names and the characters are always so fascinating as well. But my first question, I guess, comes from my own physician, Dr. Alfonso Fasano. He's my neurologist, my programmer. And he wanted me to ask you about recording from the cortex to close the loop, essentially. Because I know some of the newer devices, the RC+S, I believe, they have both, they also have a recorder up on the top of the cortex that also gets implanted. I don't know if I think it's under the skull as well. And I guess I'm wondering, how important are they to actually closing that loop, or is just getting down into the SCN going to be enough at some point?
Yeah, a key question that we are looking at. First, I can clarify that these new brain recording and stimulation device, like you have the Percept, like we've been putting in Percept, and also RC+S, an investigational version of Percept. They can record from an electrode wherever you put it in the brain. So they don't need to be attached, any of these devices, to an extra cortical lead, but any of them can be. So our specific protocol for adaptive stimulation and studies of Parkinson's physiology is using the RC+S device from Medtronic. It's an investigational only device that is quite powerful, although quite complex. In our study, we chose to have electrodes both in the basal ganglia, where you can deliver stimulation to treat Parkinson's, but also an additional electrode for sensing purposes only, not stimulation, that is inserted through the same surgical exposure, no extra holes or anything, same exposure, and that extra electrode is led posteriorly to cover the primary motor cortex, which is an important motor control structure, one of the partly the final common pathway of motor control. So we felt that as Parkinson's and other disorders are increasingly viewed as disorders of brain networks as opposed to specific sites, that having recordings from two important sites in the network, in this case, the basal ganglia and the cortex, would provide insights into the pathophysiology and potentially provide signals to use for adaptive deep brain stimulation in like the trial that you are enrolling in. The question you ask of, do you need the extra cortical recordings? Can you just record signals from the same electrode array as used for stimulation in the basal ganglia? We don't know. We are, in our studies of adaptive stimulation, however, we do have patients using the cortical signals for adaptive control, or we have some, starting to using the basal ganglia signals. So it's an open question. Can you record from the same place or as you sense, or do you need an additional site?
So I guess that's something that we're going to find out in the years to come. Okay. My next question, though, is about some of the non-motor symptoms. I know my parents would love me to ask this one question in particular, and some of the non-motor symptoms that I've experienced so far as a result of my own just continuous DBS system. However, I also wonder how much of that might be influenced by the very fact that this device is currently reading from my brain. Because in any system, when you read from a system, you affect it. It's not possible for us to read from a system without having some even minute effect. However, when you have a minute effect on the brain, the cascading effects become very difficult for us to ever measure. So I'm wondering, I guess, from what you've seen so far and all the data that you've kind of peered through, what are the notable symptoms, non-motor symptoms that you've seen that have popped up? Some of them might be side effects or symptoms of the disease itself that just progresses. So I can tell you a little bit more specifically about mine in particular if you want. So
yeah, go ahead.
Some might call it mania. I would just call it more like childlike behavior, I guess. Although parsing those two might be difficult things to do. But yeah, so we've had to like adjust my stimulation on the fly, or not on the fly, but like adjust it as I've gone each time to visit my doctor, just to make sure that those symptoms are properly controlled while still controlling my motor symptoms. So I guess I'm just wondering, have you seen many cases like this? And then coming back to my other question about recording from the brain while actually influencing it, is that something that you've also noticed?
So would you say that problem that you have had is related to medication cycles with dopaminergic medications, or is a consequence of stimulation that you've started, or both?
For me, it seems to be a direct consequence of stimulation, because every time after I left my clinic, not every time, but whenever we would stimulate in such a way that would activate those pathways, it would start up almost immediately after I left the clinic, and it would wane after like 3 or 4 days usually. Also during that period, so one of the clear signs that I have is through my speech. So sometimes it'd be more difficult for me to actually properly articulate myself during those moments as well. My parents in particular noticed this very acutely, more than I could even. So yeah, I'm just wondering, coming back to the same questions, I guess. Yeah.
Sure. Well, behavioral effects like mania, or in some people, mood depression, can be induced by DBS or exacerbating a pre-existing tendency in that regard. Part of the reason for that, we think, is in your target, presumably, is the subthalamic nucleus. Is that right?
Yes.
So part of the reason why you can get these non-motor side effects is that the circuits for motor control and emotional or cognitive control, while slightly separated in the target nucleus, are actually very close and slightly intertwined in a structure the size of a peanut. So it's difficult to really exclusively influence just the motor circuit without some of the other circuits, and that may be part of the basis for some of these problems. What you're describing is common. I definitely have patients where subthalamic stimulation amplitude is limited by the occurrence of some of these adverse effects. Yeah.
Okay.
Regarding the recording, I don't think that the actual recording from the brain is necessarily influencing the brain itself. Clearly having an electrode placed there is influencing it, although it's fairly non-traumatic. But since simply sensing the signals is not affecting the brain very much, it is affecting the device. It does drain energy from the device. And if you're not careful with how much you do sensing, you can drain too much and have to have the device, the part in the chest, the battery unit, replaced more frequently.
Now my next question, I guess, would be, because from what I understand, the placement of my device was almost perfect in that all 8 contacts produce a pretty pronounced physiological response that we can measure. However, that's not always the case. And whenever I talk about DBS, I just want to make sure that I give appropriate balance. So, and I think you're in a better position than I am to talk about when some of the times when it doesn't go right, and how do you know it's not going right? And then what is done to actually fix those cases as well?
Yes, we debate a lot about what is the optimal placement in this relatively small region, sort of peanut size region of the subthalamic nucleus. We also implant into another target, globus pallidus, which is larger. So there's even more debate about where to go in the larger structure. Nobody really knows exactly what is the perfect target. The perfect target for any person is that which relieves their motor problems the most, right? We're getting an idea that there's subregions within each of these targets that are better for certain motor signs. For example, it looks like a better anti-tremor control happens from leads that are more way in the back of the subthalamic nucleus. The better control of bradykinesia is a little bit more forward. Parkinson's dystonia may also be more posterior. Again, these are all in a very small area. So it's certainly possible to have a lead that's positioned so centrally to these circuits that you influence everything, and that's ideal. But the optimal placement for someone who's strongly tremor dominant could be a little bit different from someone who has no tremor, for example, and has other motor signs. We even debate whether it's possible to identify that perfect target by imaging alone, the MR images we use, magnetic resonance imaging images we use for targeting, or is it really necessary, critical to record physiology signals to identify that target? Is it a physiological target, or can it be an anatomic target? Those are things which have been debated in the literature. That being said, people who do this a lot have a good idea of the region of that structure in the brain that will, for most people, benefit most problems.
Okay, now there's the work of 2 other people that I'd love to ask you a little bit about as well. I don't know how much you're familiar with Andreas Horn. He was
Yes.
at Berlin. He's now, I think, at Harvard. And also
Yes.
Cameron McIntyre. So I'm going to be
Yes.
getting a chance to interview him next week as well.
Great.
Both of them, I think, do an amazing job at actually visualizing the brain and giving us really robust and very just incredible images as well that we can use. But I'm wondering, for somebody like yourself, how useful are those images in the work that you're doing?
Well, very. I mean, I know both of those folks well. This is a pretty small field. We all talk to each other and know one another. And, Andreas has done some great pioneering work in using so-called connectomics to understand mechanisms of DBS and optimal placement of DBS. And he's really leveraged a growing database of the brain connectome. What are the fibers that connect different brain structures? And there are now larger and larger databases from all sorts of people where you can have a map of the average or so-called normative connectome of the brain. And he's managed to use this very effectively for a number of studies in understanding what pathways have to be influenced by a deep brain stimulator to give best benefit. And I think that's a big contribution. I was actually been pretty amazed that you can use this so-called normalized data, that is data from a big database of other people, not the person you're actually studying at the moment, this big normalized database to say so much about what needs to be influenced. And the work on obsessive compulsive disorder and the connectome in that, and why it is that 8 different targets can influence the disorder, has really helped sort that out. And I haven't directly used the connectomic framework in, I guess, my own targeting, but I pay a lot of attention to it. And I think when as I'm doing some DBS and OCD, obsessive compulsive disorder, I'm definitely following his connectomics very much for that disorder. For Cameron, Cameron has made a number of great contributions to this field. I mean, he's really one of the original people defining the volume of tissue that is affected by DBS, the so-called volume of tissue activation, VTA, is now a common term. And, that's derived from using basic engineering principles to plot a volume of tissue activated based on the current delivered and various assumptions on the electrical properties of the brain in the vicinity. So that VTA concept was a huge contribution of Cameron and others. And more recently, he has a very influential paper, Neuron, you may be referring to, talking about holographic visualization of brain pathways. And again, I think that will be is a great instructional method for people learning the pathways. I think it's a great tool for approaching new targets. We're going to implant something new for maybe a different disorder. We want to understand a very unfamiliar, complicated area of anatomy. I haven't directly used the holographic work in my own standard targeting for Parkinson's, but again, that's partly because I've implanted thousands of leads in these structures. But I think it's great work for helping people understand in newer targets or newcomers to older targets.
Okay. Now, my next questions actually I asked yesterday also to an old postdoc of yours. I think he might have been your PhD student. I'm not exactly sure. Ray Gilron.
Yes.
And I showed him this picture. I think this picture comes from Dr. Andres, not from Lozano as well in Toronto. Can you see this right now in front of you as well?
Yes.
Okay. My question to him was this, and he said actually you'd be a better person to ask because you probably have a better answer, but I'm not exactly sure. So we'll see what happens. But so I often think about those neurons and those astrocytes and the glial cells that are all, and even the blood cells as well, that are all surrounding that electrode that's now in my brain. And I think about all that they've been through over the past 5 months, essentially, and how they're responding and how they're reacting. And I guess I'd just like to ask you, how do you think that they're responding and reacting to this foreign device that's suddenly been shoved into their environment and then trying to communicate with them in some way?
Well, you're asking a key question that's motivated my work for, decades, which is, what is DBS actually doing? It's scientifically speaking a messy technique because there's so many, as your picture shows, so many different neural elements and non-neural elements. There's neurons themselves, there's various kinds of synapses, there's the support structure, astrocytes of the brain, there's blood vessels, and these are being now influenced by a new electric field, and what is it really doing? Our best understanding now, our current working model of what DBS is doing in that complicated network is so-called desynchronization. So there's a concept evolving over the last 20 years that what happens in the brain in Parkinson's is, as an ultimate result of dopamine loss, there are downstream effects that involve abnormal synchronization of brain cells, so that usually when you're doing specific movements, brain cells come in and out of synchronization in a very specific way to perform certain tasks. Now in Parkinson's, it's felt that brain cells are firing in synchrony with each other too much. And in fact, they do it at a certain frequency, so-called beta frequency, which is shown in part B of your graph there, that there is an excessive activity in this sinusoidal electric field activity in the beta frequency. You can record that from the DBS electrode, but it reflects the synchronized activity of the thousands of neurons in the vicinity of the reporting electrode. So paradoxically, when we stimulate at, what's your frequency? Do you know what frequency your stimulator is set at right now?
Yeah, 2.9 and 1.9. I don't know if you can see.
And how,
my left side is 2.9, my right side is 1.9.
So that's the amplitude. How about the frequency number of pulses per second? It's usually like 130, 180, something like that.
I'd have to ask my.
No. So usually it's between 130 and 180 pulses per second. And paradoxically, if you stimulate at this monotonous frequency of 130 to 180 pulses per second, you desynchronize, that is, you prevent this excessive tendency to fire together at the lower frequencies like 20 hertz. So our working model of what DBS is doing right now is it's interrupting this excessive synchronization at low frequencies by overriding it with higher frequencies. But it's a fascinating area because when DBS started, that wasn't really anticipated to be a mechanism of DBS. Now it turns out probably to be an important one.
Now, can you just tell me how much time we have? Actually, I want to be very cognizant of the fact I don't want to take up too much of your time, but I do have like some other questions that I'd love to ask.
Sure. Maybe another 15 minutes or so, if that would do it.
Squeeze in as much as I can into there.
Sure.
Talking a little bit more about the future then of DBS. So I have this kind of crude schematic that I drew for myself of where I think we're going and kind of where I think we need to go in some sense. So basically what this is right now on the left side, we have this the current version of DBS. And on the right side, we have what I think is where the field should go using these new graphene-based solutions in particular. So what I'd envision is that at the bottom of that electrode, what you'd have is the STN or whatever your target area is. And then each of those little dangling things that are coming out would be graphene-based tips. And at the end of them, there'd be a sensor and an electrode. So they could stimulate and record at the same time, hopefully. But also more importantly, I think they'd act more physiologically like a neuron in that they'd be able to grow and expand over time, probably using some kind of advanced either miniature robotics or maybe driven by machine learning algorithms that would tell each one where to go and how to exactly to innervate the chosen target area. And I'm wondering, do you see this as the future? And is this at all realistic in my lifetime or the lifetime of maybe the next generation? When do you think something like this might come about? If it actually is realistic or not? And would it be a better?
I think it is realistic. I think that, we are moving toward higher so-called channel counts, right? On the left, you have 4 channels shown, and the newest electrodes have 8 channels because several of those on the left are subdivided. But we're heading toward electrodes of greater channel count and greater flexibility. There's also kind of an implication from your drawing that maybe with very fine tips, you could record single brain cell activity in addition to this grouped synchronized activity that we now record from the bigger electrodes. I think the key thing to knowing exactly how to design these future electrodes, however, is knowing more about what conventional deep brain stimulation is actually doing, right? We don't understand it in enough depth to really know what the next better electrode design is, right? Once we do understand it, we can say, oh yes, based on that understanding, we need 20 contacts, 30 contacts, we need certain kinds of pulses, to do what we want to do in the network. So I think you're on the right track, but the engineering design has to follow the brain understanding.
Okay. Now, I guess my next question would be about depression. You recently, I think, came out with some pretty cool work from what I could see. The videos look really cool anyways, that UCSF just published about some of the work they've done in depression. And I guess just broadly, how does it compare? What's like the risk-reward ratio in comparison to DBS for Parkinson's at the moment? And is it the same kind of adaptive systems that you're using there as well?
Yeah, you're referring to a paper on adaptive stimulation in one subject that was published with the first author, Catherine Skangas, and then my colleagues, Eddie Chang and Andrew Crystal as the senior authors, and I was involved in that work as an author as well. It's a highly investigational study in compared. So the procedure you had, deep brain stimulation in Parkinson's, is labeled by device manufacturers as something they have studied. It has good outcomes data. It has known safety data. When you get to the more unusual indications like depression, chronic pain, there is a lot less data, and these are also investigational uses. There was a lot of hope in deep brain stimulation for depression 15, 20 years ago. Dr. Lozano with Helen Mayberg had a very influential paper about 15 years ago on so-called Area 25 stimulation with some nice promising results. A few investigators like Helen Mayberg have continued to really dive deep into these targets and figure out how to make it work more robustly. Part of the problem with DBS and psychiatric disorders is you'd have a few cases where it would clearly work extremely well, but many cases where it didn't. There was not enough predictability to really go mainstream if something is going to work in 40% of people and you don't know which 40%. So a lot of the work in the last decade or so, and Catherine Skangas's paper is part of this work, is really designed to personalize this therapy, to identify signals in a particular patient's brain that reflect the mood disturbance in this case that they're having, and design a protocol, a stimulation protocol to specifically interrupt that. So that work is important in the paradigm of understanding the network and interrupting it selectively. And so it's a nice advance, along with Helen Mayberg's great, advances in this area over many years. I'm optimistic about DBS and psychiatric disorders, but it's a harder problem than movement disorders, because assessing patients is more difficult than in a movement disorder, and we have even less understanding of the circuits in those disorders. But the great thing about your device and similar new DBS devices that sense brain activity, they now give us the opportunity to understand what we're doing as we're actually doing it.
Oh, wow. My next question then would be about those circuits themselves. Can you see this picture here?
Yes, I can.
Okay, that's kind of the classical understanding from what I gather about how DBS kind of works, or what the STN is doing, I should say. If you look at that picture on the bottom left, we have the 3 regions and how they're divided up, kind of. I think this is the work actually of Andreas, but I'm not exactly sure. But I guess the more important question for you, though, is how accurate is something like this? I mean, obviously, we're just generalizing from a lot of different brains, but if we were to generalize, is that more or less correct, or is that something that we should just be throwing out and starting over again and trying to really understand what's going on?
So what you've shown is something I mentioned a few minutes ago, which is that within the subthalamic nucleus, there's in principle a separation between the motor movement controlling areas, which are in pink in your diagram, the cognitive areas, which are in blue in this, and the emotional limbic areas in green. The theory, the model behind which our surgery is based is partly just what's shown here. The model is that, oh yeah, you can go anatomically into a certain part of the target and influence the motor part, the pink area, but be further enough away from the blue and green areas that you don't have non-motor side effects. This story, though, is not really completely true. In fact, there is a fuzzy zone between these areas, and there's much more overlap and intertwining than this diagram leads us to believe. So is it useless? No. In general, as you go to a certain part of the subthalamic nucleus, you'll have more limbic structures, and another area will be more motor. But at the borders, there's a lot more mixing than that diagram would lead you to believe, most likely.
Okay, I guess I only really have one last question for you, and in many ways, I think it's the most important question that I could be asking you right now. And it's about statistics in general, and what kind of statistics do you think patients like myself should have access to before we actually decide whether or not to have DBS, and where we want to have it as well, and maybe who we want our surgeon to be even. Because there's so much variability between sites, and there's so much variability between, even between countries as well. So, and between which devices we're going to pick and which leads that we want in our brains. So, and I've heard that, I've heard both sides of this argument, but I'm just more curious, I guess, from your perspective, because I think you have a very unique perspective in many ways about, what do you think? I mean, should I have access to all the data that we have and be able to have a whole database that I can query and ask whatever I want and get back whatever answers I want? Or should I not have access to something like that?
More information is better. And so basically, yes, you should have access to any information that helps you make a decision about your own health. The way to decide, of course, to have a surgery, and the way we decide if we should recommend a surgery, is what do we estimate the risks are versus the benefits. Now, fortunately, in deep brain stimulation Parkinson's, so thousands of patients have been done and studied. We know pretty well what is the rate of benefit if you select patients with certain characteristics and your surgery goes well, in a very high likelihood of a major benefit, certainly over 90%. And the risks, likewise, are relatively well known in groups that are experienced with this. around a 1% risk of stroke from bleeding, around a 2% risk of a hardware infection that could require further surgery for removal. And those are fairly favorable odds for someone who stands to benefit a great deal. As far as experience, there's not a consensus on everything about these surgeries. Just to give you an example of some of the lack of consensus. In Europe, and I think parts of Canada, there's only one brain target for Parkinson's. It's the subthalamic nucleus. Actually, in the United States, there's more than one. We often implant the globus pallidus, which is not done in Europe for Parkinson's. It's done in other disorders. And, they're thoughtful, smart people there, and so are we here. And yet we have very different practice patterns in that way. So that shows you that there is not a consensus on a number of important aspects of the story. Surgical outcomes, of course, in any surgery correlate with the experience of the group. So a patient should ask, how experienced is this particular group in doing it? On the other hand, it's possible to overestimate the value of experience. I have patients sometimes come to my clinic and say, "Oh, Dr. Starr, you've been doing this for decades. We've heard that you're one of the best. And so I know that you never have a complication." I have to stop them and say, "Actually, I've been doing this a long time. I like doing it. I always try to make it better. I do the best job I can. But my patients have complications too, unfortunately. We try to minimize those, but they still happen. So patients should ask their team, their surgeon, in your hands, in your practice, what are the benefits and what are the risks?"
I said, if you have time, I have one last question that I'd love to ask.
Absolutely, sure.
And that is in regards to the general population that's out there and to more patients that are out there as well. Because I'm always kind of cognizant of the fact that a lot of patients don't have the time to do what I did and try to research everybody and talk to everything. So I guess my question for you is, short of having any kind of cognitive deficit, but how much do you think a patient actually needs to be aware of and to know about this procedure in order for them to give informed consent and to actually be able to go through it for themselves?
You're asking a great question in neuroethics, and this becomes even more important in disorders. There's disorders of impaired consciousness, or in someone who is very cognitively impaired. Are they consentable for their procedure? There's techniques now in the neuroethics field to assess this. For example, in the consent process, doing a questionnaire of patients and asking certain questions to find out how much of the consent process did they really understand and retain. And it sometimes can be quite low, and it's distressingly low. I think, the more informed you are, the better. And I think when patients are disappointed or angry after this surgery, most patients are happy, right? Most patients get nice results. It's like, it's like a reprieve on a serious problem they've had, and it's great. But there are some patients who are disappointed or angry. And what does that usually come from? It usually comes from, incorrect expectations, right? They would always go perfectly, or that, as soon as the first programming session, you flip a switch and instantly they're better. Those kinds of things. Or they may think that cognitive problems or mood problems will get better from DBS. And at this point in time, those things don't get better. So the more people know about the realistic elements of the surgery, the better they're going to feel afterwards.
Well, hopefully we've done a little bit in pushing that forward, making sure that more people are aware of the benefits and the risks of going through something like this. Yeah, thank you so much for taking the time to speak with me today. It's really been an honor, and thank you for everything that you're doing as well, and thank you for all the patients that you've also helped along the way. I don't know if anybody's actually done more implants than you have. Maybe there is, maybe there isn't.
Well,
yeah.
Maybe Andres, in Toronto, or Sunil, or there's a few folks that do this in a big way. There's a number of groups that we are all colleagues that do this in a high level way. I just want to say, Ben, it's great to have patients like you who really get into this, create educational materials for other folks, serve on boards of companies making devices, advisory panels to grants and companies. This is really important. And so I salute you for doing that. It really is a big service. So thank you.
Thank you. And on that, I think we'll say goodbye to everybody. Thank you
Okay.
for watching. Thank you for listening. And we'll see you all again soon. Bye for now, though.
Okay. Have a good evening. Bye.